Bismillahirrahmanirrahim. I'm Fawad Assistant Professor, Department of Pharmacy. Welcome to the course Pharmacology and Therapeutic. Today we'll discuss the remaining part of the anti-epileptic drug. In this in this lecture we discuss about the anti-epileptic drug pharmacology, drug interactions, and treatment significance. And status epilepsy. After watching and listening this, student will know about the epileptic drugs, interactions, treatment, and significance. Benzodiazepine used for the absence seizure and sometimes myoclonic. Like benzodiazepines are mostly used for the absence seizures or most specific anti-epileptic drugs among the benzodiazepines appearing to be selected for the GABA activation in the reticular formation, leading to the inactivation of T cell calcium channels. Hence, it is used for in the absences. And normally, the absences are because of the activation of T type cell T type calcium channels. Hence, used for so most of the specific among events appear to be selected for GABA activation in reticular formation, leading to the inactivation. So normally the specific drug in absences is ethosuxamide. Ethosuxamide basically inhibit the T-type calcium channel. Sedation may lose its effectiveness due to the development of tolerance. In the clonazepam basically it is an benzodiazepine used in absence seizure and myoclonic. They have the GABA activation in reticular formation leading to the inactivation of the T-type calcium channel. Lorazepam and diazepam. Benzodiazepine used as a first-line treatment in status epilepsy. Delivered IV fast-acting, sedating phenobarbital. Like barbiturate used for partial seizure, especially in the neonates. Oldest of the current used anti-epileptic drugs. Barbiturate used for the partial, especially in the neonates. They have very strong sedation, used for the partial. They are more potent from the benzodiazepine. So, but used for the partials, especially in the neonates. Oldest of the currently used anti-epileptic drug. Very strong sedation. Cognitive impairment, behavior changes, very long half-life up to 5 days, induces cytochrome P450 enzymes so that they have drug interactions. Tolerance may arise risk of dependence. Primidone, another barbiturate metabolized to a phenobarbital, and phenobarbitals are now seldom used in initial therapy owing to the side effect. So they are phenobarbital are mostly used in the children's, strong sedative, produces cognitive impairments, long half-life, tolerance may be arises so there is a risk of dependence. So receptor binding GABA and benzodiazepines. Normally, GABA and the binding site of benzodiazepines they're different from the benzodiazepine binding site is different from the binding GABA. This is a GABA A receptor. It's a pentameric structure, GABA 2 alpha, 2 beta, and 2 gamma. GABA bind with the alpha and beta subunit bind between the alpha and beta subunit, where the benzodiazepine bind into the benzodiazepine pocket, which is alpha and gamma subunit. Binding of the GABA is enhanced by the benzodiazepine, resulting in greater activity of the chlorotrin. Basically, the normally benzodiazepine enhances the binding of the GABA, increase the frequency of binding of the GABA receptor because it is a ligand based. They have ligand based activity. So entry of calcium hypochlorite then if GABA bind with the alpha and beta subunit. So the chloride chloride ion channels open and cause making it difficult to depolarize, therefore reduces the neuronal excitability. Antiepileptics are primarily act on the GABA, like tiger being interfering with the reuptake of them. Normally it blocks the tiger being blocks the GABA reuptake, vagobating uh, elevate the GABA levels by irreversibly inhibiting its main catabolic enzyme GABA transaminase. Normally, vagobatin inhibit the catabolism of the the GABA. So increase the level of the GABA by inhibiting the catabolic enzyme that is GABA transaminase enzyme. So these are the first anti-epileptic drug target, which is enhances the GABAergic stimulation. So we can simply use the like benzodiazepines or barbiturates, majority which act on the GABA A receptor and increase the chloride ion channels, resulting in the reduction of the excitability. But other drugs are like by blocking the GABA transaminase enzyme like avagopitin decrease the reuptake of the GABA by increasing the GABA in the synapses increase the decrease the excitability. So sodium channel as a anti-epileptic target like neuron fires at higher frequency during the seizure. Action potential generation is dependent on sodium channels. Neurons fire at higher rate during the seizures, so action potential generation is dependent upon the sodium channels, obviously. Use dependent or time dependent sodium channels blocker reduces the high frequency firing without affecting the physiological firing. A use dependent or time dependent sodium channel blocker reduces high frequency firing while without affecting the physiological firing. These are sodium channel blocker. So sodium channel blocker use dependent or time dependent sodium channel blockers reduces the high frequency firing not affecting without affecting the normal or physiological firing. Mechanism of action. Like that primarily act on the sodium channel. Phenytoin, carbamazepine block the voltage dependent sodium channel at high firing frequency. Use dependent. Ox- Oxcarbazepine block the voltage dependent sodium channel at high firing frequency. Also affect the potassium channel. Zonisamide block the voltage dependent sodium channel and T-type calcium channel. So this is also this may be used in case of the absences of the zonisamide because of the blocking inhibition of the T-type calcium channel, which is mainly responsible, which may be responsible or may be the reason of the absent seizure. Phenytoin. This is a first line for partial seizure. Some used for tonic-clonic seizures, highly bound to the plasma proteins, displaced by the valproate, induces cytochrome P450, resulting in an increase in its own metabolism. But its metabolism is also increased by alcohol and diazepam. So highly bound to the plasma protein, displaced by the valproate, induces cytochrome P450, resulting in increase in its own metabolism. But its metabolism is also increased by alcohol and diazepam. Sedating, obviously sodium channels are blocked, which is the main depolarizing agent. Then the CNS we should be depressed. So foxyphenatine produce prodrug phenatine used for IM injection. In the aging phenatines like convert into inactive metabolite, like agents that stimulate the metabolism of phenatine, like carbamazepine stimulate the metabolism, while the phenatine, while the agents that inhibit the metabolism of phenatine are chloramphenicol, dicamerol, cimetidine, sulfonamide, and isoniazid. So they have drug interactions with they are drugs which increase the metabolism like carbamazepine, and there are some agents which decrease the metabolism of the phenatine. Carbamazepine Carbamazepine, a tricyclic antidepressant used for the partial seizures, some use in tonic-clonic seizures, induces cytochrome P450 resulting in increase its own metabolism. It's like specifically we discussed in the last slide, like phenatine. There are some agent which increases the metabolism of the phenatine, and this is the carbamazepine. Carbamazepine is one of the example. Like sedating agranulocytosis and plastic anemia, elderly patient leukopenia, 10% patient hyponatremia, nausea, and visual disturbance are mostly noticed specifically in the carbamazepine. Carbamazepine metabolism is also inhibited by some agents like cimetidine, diltiazem, erythromycin, isoniazid, propoxyphene, etc. Oxcarbazepine. Newer drugs closely related to carbamazepine approved for monotherapy and add-on therapy in the partial seizures. May also augment the potassium channels. Some induction of the potassium p-cyclone P450 system, but much less than will be seen with the carbamazepine. They have some induction, but less as compared to the carbamazepine. Sedating, but otherwise less toxic than the carbamazepine. They are sedative, but the toxicity level of the carbamazepine is more as compared to oxcarbazepine. Lemofagine. So add-on therapy or monotherapy for refractive partial seizure. So this is an add-on like used with some some other anti-epileptic drug or monotherapy for the refractive partial seizure. Also inhibit the glutamine release and perhaps the calcium channel like pleiotropic. Metabolism affected by valproate, carbamazepine, phenobarbital, and phenatine. So the metabolism affected by valproate, carbamazepine, phenobarbital, and phenatine. It is less sedating than other anti-epileptic drugs. Severe dermatitis in 1 to 2% of the pediatric patients. Calcium channels as a target. Calcium channels blockers have not proven to be effective anti-epileptic drugs, but in case of absence, these are caused by the oscillation between the thalamus and cortex that are generalized in thalamus by the T-type calcium channels. So here, that's why T-type calcium channel blockers are effective in case of the absence seizures, because they are caused by the oscillation between the thalamus and cortex that are generalized in thalamus by the T-type calcium channel. So ethosuximide is a T-type calcium channel blocker, acts specifically on the T-type calcium channels in thalamus and is very effective against the abscesses. It has long half-life, causes GI disturbances, less sedating than other anti-epileptic drugs. Gabapentin and its second generation derivative pregabalin, like they act specifically on calcium channel subunits called alpha 2 gamma 1. It is unclear how this action lead to their antiepileptic effect, but inhibition of the neurotransmitter release may be one of the reasons. Gabapentin expression calcium channel subunits. It is unclear how this lead to their effect. It is unclear how this action lead to their antiepileptic effect, but inhibition of neurotransmitter release may be one of the reasons. Used in add-on therapy for partial seizures or on tonic clonic seizures. Less sedating than other classical anti-epileptic drugs. What about potassium channel? Potassium channels have important inhibitory control over neuronal firing in CNS, repolarizing membrane to end action potential. They have important inhibitory control over neuronal firing, repolarizing membrane to end action potential. Potassium channel agonists would decrease the hyperexcitability in the brain. So far, the only antiepileptic with the known actions on potassium channel is valproate. Retiagavine is a novel antiepileptic drug in a clinical trial that acts on a specific type of voltage-dependent potassium channels, valproic acid. First line for the generalized seizure, also used for the partial seizure. Block the sodium channel and enhance the GABAergic transmission. Highly bound to the plasma protein and inhibit the cytochrome P450 enzyme. So they use for generalized season, use for the partial. They block the sodium and GABA transmission, highly bound to plasma protein, inhibit the cytochrome P450 system. CNS dependent depressant, GI disturbances, hair loss, weight gain, and they are teratogenic, rare hepatotoxicity. So if absence in seizure drugs, like drugs on the basis of the clinical, uh, like on the basis of seizures, like chronic seizure, carbamazepine, phenytoin, valproic acid, lamotrigine are preferred. In absence seizure, ethosuximide, valproic acid, clonazepine, clonazepam. A myoclonic seizure, we can give valproic acid, clonazepam, lamotrigine. Backup and adjunctive drugs like carbamate, gabapentin, lamotrigine, levetiracetam, phenobarbital, tigerbean, topiramate, vigabatrin, zonisamide. So regulation of neurotransmitter release. Several anti-epileptic drugs have action that result in the regulation of neurotransmitter release from the presynaptic terminals such as lamotrigine in addition to their noted actions on ion channels or receptors. Drug interactions. Many anti-epileptics are notable inducers of cytochrome enzymes and a few are inhibitors. Of the classical anti-epileptic drugs, phenytoin, carbamazepine, phenobarbital, and pyrimidine all are a strong inducer of cytochrome P450 system. They are autoinducive, in other words, they increase their own metabolism. Valproate inhibit the cytochrome P450 system. So most anti-epileptic drugs undergoes complete or nearly complete absorption when given orally. Phosphonatine may be administered intramuscularly if the intravenous access cannot be established in case of the frequent repeatable seizures. Diazepam available as a rectal gel have been shown to terminate the repeatable seizures and can be administered by family member at home. Phenytoin, phenytoin, phenobarbital, diazepam, lorazepam, valproate are available as IV preparation for journal for emergency use. Most antiepileptics are metabolized in liver by hydroxylation or conjugation. These metabolites are then excreted by the kidney. Gabapentin undergoes no metabolism and is excreted unchanged by the kidney. Treatment of the first consideration is efficacy in stopping seizure. Because many antiepileptic drugs have overlapping, the most appropriate drugs can often be chosen to reduce the side effect. New drugs tend to have less CNS depression effect. Potential of the long-term side effects, pharmacokinetic and cost are other considerations. Monotherapy is preferred, better patient compliance, less side effect. Why? Why we prefer monotherapy? Because they have most of the chronic seizures